Hi guys, and welcome to our model on the joints of the lower limb. Joints are regarded as junctions between two or more bones. In the case of the lower limb, we have a total of about 8 sets of joints. This includes the hip joints between the hip bone and the femur, the knee joints between the femur, the patella, and the tibia, the tibiofibular joint, the ankle joint, and then we have some joints found in the feet, like the intertarsal joint, the submetatarsal joint, the metatarsophalangeal joint, and the interphalangeal joint. In the case of this particular model, we talk about just a few of these joints. The most important one includes the hip joint, the knee joint, and the ankle joint. And these are the joints we'll talk about in this model. Now, all three of the joints, the knee, the hip, and the ankle joint, are regarded as large synovial joints. Now, what makes them synovial joints is the presence of a number of components that surround the joint. This includes the fibrous capsule at the outermost aspects, as you can see, the synovial membrane just lining the fibrous capsule. You can see that in orange, and internally, the synovial cavity, which is a space between the two bones. Synovial cavity will contain synovial fluid. Uh, Then the articular cartilages are just hyaline cartilages lining the surfaces of the bones in contact. So you can see the structure in blue. We have an articular cartilage on one bone, and the other articular cartilage on the other bone. And this is to prevent wear and tear of the joints as the bones are moving along the synovial cavity and fluid. And we have some structures surrounding the joints. Ligaments, tendons, and bursae are also structures that are found surrounding a synovial joint. So a joint that has a combination of all six of these components I just mentioned is regarded as a synovial joint. Let's start with the hip joint. The hip joint is also called the coxal joint. It's the joint that exists between the femur distally and the hip bone proximally. And we'll talk about everything we need to know about the hip joint, from the type to the articular surfaces to the blood supply, all the way down to the movements and the muscles involved. The hip joint is a joint regarded as a ball and socket joint. This is based on shape. Its ball and socket nature stems from the fact that the articular surface of the femur has a ball-like appearance, a spherical appearance, and the articular surface from the hip bone has a socket-like appearance, as you can see. So, and the contact between two of these surfaces gives that ball and socket feature. Another type or form of classification for the hip joint is the fact that it is regarded as a multi-axial joint. It's multi-axial because of the fact that the hip joint has um, allows for different range of movement. Okay, we could abduct and adduct at the hip joint. We could flex and extend at the hip joint. We could circumduct at the hip joint. We could internally and externally rotate at the hip joint. So the fact that we could have multiple planes of movement occurring at that joint is what makes it multi-axial. And as I already discussed, based on the structure, we regard the hip joint as a synovial joint. One of the articular surfaces of the hip joint is includes the head of femur, as I described, as what forms the appearance of the hip bone, and then the acetabulum of the hip bone, that's what forms the appearance of the socket. And you can see that it fits into one another well, and this is in contrast to what we see in the shoulder joint. The shoulder joint also has a ball and socket um, appearance or configuration, but the difference is that the ball of the humerus doesn't fit too well on the glenoid cavity of the scapula. The component of the hip joint includes the joint capsule and the acetabular labrum. The joint capsule is formed by the combination of the fibrous capsule on the outside and the synovial membrane on the inside. Fibrous capsule tends to attach proximally to the rim of the acetabulum and then attaches distally to the neck of the femur. That neck, at the point where it's attaching distally to the neck of the femur in front, it tends to attach to the intratrochanteric line, whereas at the back it attaches to the intertrochanteric crest. The acetabular labrum is a part of the it's a form of fibrocartilage that is found at the rim of the acetabulum. It helps in deepening the acetabulum to make the entry of the head of the femur to fit perfectly into the depth of the acetabulum. So that's what the acetabular labrum is there for. It is similar to what we see in the shoulder joint with the glenoid labrum, just as in contrast, the depth of the acetabular fossa is greater compared to that we see in the glenoid cavity. Let's talk about the ligament of the hip joints. We have a total of about 6 ligaments of the hip joints. Three of these ligaments are regarded as extracapsular ligaments. The rest are regarded as intracapsular ligaments. So the extracapsular ligament includes the iliofemoral ligament, the ischiofemoral ligament, and the pubofemoral ligament. Then the intracapsular ligament includes the ligamentum capitis femoris, the retinacular ligament, and a very small ligament found between the um, found spanning that gap found in the acetabulum called the acetabular notch, and that ligament is called the transverse acetabular ligament. So this picture depicts for us the intra and the extracapsular ligament. On the right side, we see the intracapsular ligaments there listed. The iliofemoral ligament starting is the strongest of the three extracapsular ligaments. It covers the hip joint anteriorly. As you can see, it wraps around the entire joint, covering it anteriorly. And its major function is in the resistance of hyperextension of the hip joint. It helps in maintaining the hip joint in its locked and stable configuration. Um, it has two bands. It has this Y-shaped structure, has two bands to it. The lateral band of the iliofemoral ligament tends to limit adduction, ADD abduction, whereas the medial band tends to resist lateral rotation. But overall, the iliofemoral ligament tends to resist hyperextension. Then we have the pubofemoral ligaments just medial to the iliofemoral ligament. You can see the pubofemoral ligaments here. This is a ligament that also covers the hip joint anteriorly. It blends with the fibrous capsule, and it tends to be involved in preventing over abduction. So it prevents hyperabduction. So while the iliofemoral is preventing hyperextension, the pubofemoral prevents hyper abduction. Then at the back of the knee joint, of the hip joint rather, we have the last extracapsular ligament called the ischiofemoral ligament. The ischiofemoral ligament is the weakest of the three. You can see it posteriorly, covers the joint posteriorly, and in terms of its function, it helps in limiting medial rotation of the joint. So medial rotation is limited or resisted by the ischiofemoral ligament. Moving on to the intracapsular ligament, we have the ligament of the head of femur. This is a ligament that runs um, from the acetabulum to the head of the femur. It tends to attach to the head of the femur at a point called the fovea capitis. This is a depression on the head of the femur that lacks articular cartilage. The entire head of femur tends to be surrounded by articular cartilage, except at that fovea capitis. So what does this ligament of head of femur do? It's a ligament that is weak, but is involved in conveying branches of neurovascular structures. Particularly, it conveys the obturator artery towards the head of the femur, and that obturator artery would be involved in supplying the head of the femur. Then we have the last set of ligaments found at the neck. That ligament is called the retinacular ligament. It is derived from fibrous capsule. It reflects along it reflects back along the femoral neck towards the femoral head, and it's just like the ligamentum femoral capitis or ligament of the head of femur. The retinacular ligament also helps in conveying small arteries to the head of the femur and also to the neck of the femur. Let's talk about the blood supply to the hip joint. The hip joint is supplied by a number of different arteries. These arteries tend to interconnect to form anastomosis. And in terms of the blood supply, we have the first of all the artery to the head of femur. We talked about this as one of the arteries carried by the intracapsular ligament known as the ligament of the head of femur. And that ligament tends to run into the femur through that fovea capitis found on the head of femur. Aside the artery to the head of femur, we also have what we call the trochanteric anastomosis and the cruciate anastomosis. This is a network of various branches of vessels coming from about four different arteries each. For a trochanteric anastomosis, that is formed by branches coming from the superior gluteal artery, the inferior gluteal artery, the lateral circumflex femoral artery, and the medial circumflex femoral artery. All these arteries give off branches at anastomose from the trochanteric anastomosis found somewhere around the greater trochanter. Then the cruciate anastomosis is also formed from branches of four different arteries. These include branches coming from the profunda femoral artery, which is the first branch, the inferior gluteal artery, and then the lateral and medial circumflex femoral artery. So anastomosis coming from each of these arteries give rise to the cruciate anastomosis, or rather branches coming from each of these four arteries gives rise to the cruciate anastomosis, and we can see that somewhere around the lesser trochanter. The reason why we call it cruciate anastomosis is because the combination of all the four arteries tend to give rise to a form of cross, and that cross is what gives the name cruciate anastomosis. The nerve supply to the hip joint tends to follow the Hilton's law. Now, the Hilton's law states that the nerve supply to muscles acting on the joint also supplies that joint. So, in the case of the hip joint, we have the femoral nerves, the obturator nerve, sciatic nerve, superior gluteal nerve, the nerve to the quadratus femoris, and the accessory obturator nerve as nerves that tend to supply muscles around the hip joint. Hence, they are nerves that supply the hip joint itself. Let's talk about the movement and the muscles of the hip joint. The hip joint is a multi-axial joint, and it is involved in a number of movements across different planes. We have the flexion and extension movement on one plane, abduction adduction movement on another plane, internal and external rotation on another plane, and then circumduction, which is a combination movement. The muscles involved in each of these movements, for flexion, we have the iliopsoas, the sartorius muscle, the pectineus muscle, the rectus femoris. All adductors are slightly involved in flexion, and then a very important fascia of the thigh called the tensor fasciae lata is also involved in flexion of the hip joint. For extension, we have the gluteus maximus and the hamstring muscles. The hamstring muscles are a combination of three muscles that are found at the posterior part of the thigh. We'll talk about that when we get to the muscles of the lower limb. For abduction, we have the gluteus medius, gluteus minimus, the tensor fasciae lata, and the sartorius muscle. For adduction, we have the adductor muscles, which includes the adductor magnus, adductor brevis, and adductor longus. We have the brachialis muscle, the pectineus muscle, and the obturator externus muscle. For internal rotation, which is also called medial rotation, we have gluteus medius, gluteus minimus, and the tensor fasciae lata. For external rotation, also called lateral rotation, we have piriformis, obturator internus, gemellus superior and inferior muscle, the obturator externus muscle, quadratus femoris muscle, and the gluteus maximus. Circumduction is a combination of all these movements, and all the muscles that we mentioned are used in combination during the performance of the movement of circumduction. This is just an image showing us different forms of movement at the hip joint. Flexion is the movement of the thigh towards the trunk. Extension is the movement of the thigh away from the trunk. We have abduction, abduction, and adduction. Abduction is the movement of the thigh away from the midline. Adduction, ADT, is a movement towards the midline. Internal rotation and external rotation are similar to abduction and adduction. It's just that these are rotatory movements across the hip joint. For lateral or external rotation, we are moving the thighs away from the, or rotating it away from the midline. Internal rotation, we are rotating it towards the midline. The second important joint of the lower limb is the knee joint. The knee joint is a compound joint. The reason why it's a compound joint is because it's a joint between at least three different bones. It's a joint that exists between the femur superiorly, the tibia inferiorly, and the patella anteriorly. Hence, the reason why it's a compound joint. So we usually say that it's composed of two joints in one: the femoral tibial joint, that's the joint between the femur and the tibia, and then the femoral patella joint, the joint between the femur and the patella. One important thing to note about the knee joint is that it's the largest joint in the body. In terms of its type, the knee joint is regarded as a modified hinge joint. The word modified is important to note because although it's hinge, and because it's hinge, we refer to it as a uniaxial joint. Um, Ideally or typically, the knee joint has a form of rotatory movement, and that rotatory movement makes it to not be a purely hinge joint, but a modified hinge with properties of rotation. If we are breaking it down into its two major components, the femorotibial and the femoropatellar, we refer to the femorotibial joint as a condylar joint and the femoropatellar joint as a saddle joint. What are the articular surfaces involved in forming the knee joint? For the femur, the lateral condyles of the femur would be in contact with the lateral and medial condyles of the tibia. So lateral and medial condyles of the femur articulate with the lateral and medial condyles of the tibia to form the femorotibial joint. Then for the femoropatellar joint, we have the articular surface of the tibia articulating with the patellar surface of the femur, and that will give rise to the femoropatellar joint. Let's move on to the components of the knee joint. Remember that the knee joint is a synovial joint, hence it would have the synovial complex, and that will be a combination of joint capsule, ligaments, and bossas. In the case of the knee joint, the joint capsule, which is the fibrous capsule of the knee, and the synovial membrane are found internally, and they surround the entire joint. For the ligaments of the knee joint are divided into two different sets, similar to what we saw in the ligaments of the hip joint. We have what we call extracapsular ligaments, ligaments found outside of the fibrous capsule, and we have the intracapsular ligaments, ligaments found within the fibrous capsule, within the synovial space. As you can see in the image down below, is we have some ligaments shown here. You can see ligaments at the side here, medial and lateral collateral ligaments. These are examples of extracapsular ligaments. And if you look closely, you see ligaments within the joint. They are not labeled here, but we could see them attached to structures called the lemniscus, also ligaments. So the lateral and medial lemniscus alongside its ligaments in the center are examples of intracapsular ligaments. We'll talk about that in the next slide. So extracapsular ligaments include ligaments like the patellar ligament, the medial and or tibial collateral ligament, the lateral or fibular collateral ligament, the oblique or popliteal ligament, and the arcuate popliteal ligament. Each of these ligaments have their uses and their sites. Patellar ligament, for example, is an anterior ligament that extends um, from the tendon of the muscle of the anterior part of the thigh towards the patella. It's a strong flat ligament about 8 centimeters in length, and it has superficial and deep fibers. Superficial fibers are usually continuous over the patella with the tendon of the quadriceps femoris superiorly, and superficial fibers, or rather the deep fibers, tend to be separated above from the synovial membrane by what we call the infrapatellar fat pad, and it also separated below by the deep infrapatellar fossa. We'll talk about each of the fossas later on, but these are just some peculiarities about the patellar ligaments that you should know about. The tibial collateral ligament is a strong triangular ligament. Please take note of the word triangular. It's a strong triangular ligament found on the medial side or tibial side of the knee joint. It is broad. It has a flat band that is closer to the posterior than to the anterior aspect of the knee. One important thing to note about the tibial collateral ligament is the fact that it tends to be attached or tend to blend with the fibrous capsule and the medial lemniscus. This is the medial collateral ligament. If you notice, you have it attaching to this intracapsular part of the knee joint called the medial lemniscus. So the medial lemniscus, alongside the fibrous capsule, are in close attachment to the medial collateral ligament. This is contrast to what we see for the fibular collateral ligament. Fibular collateral ligament is a ligament that is strong and round. It's found on the fibular part or lateral part of the knee joint. Unlike the medial collateral ligament, the fibular collateral ligament it is not attached to the lateral meniscus or fibrous tissue. You can see the lateral meniscus sitting by itself, and it is separate from the fibular collateral ligament. You can see this big space in between them. And what tends to separate them is usually the tendon of some muscles, tendon of the popliteal muscle, and then some vessels, the inferior genicular vessels. So the inferior genicular vessels and the popliteus tendon tend to separate the lateral collateral ligament from the lateral meniscus. The other ligaments are not so important to remember. Oblique popliteal ligament, for example, is an expansion of the tendon of the semimembranous muscle. And then the arcuate popliteal ligament is a Y-shaped band of fibers that usually stems from the head of the fibula. These ones are not so highly tested. The ones you need to pay attention to be the first three: patellar ligament, medial tibial collateral ligament, or lateral fibular collateral ligaments. So moving on to the intracapsular ligament, this includes the medial and lateral meniscus, shown here, the lateral meniscus in red, the medial meniscus in purple. Then we have the anterior and posterior cruciate ligaments. It's a ligament found at the center of the knee joint, what we call the intercondylar fossa. And then we have the transverse ligaments. Each of these ligaments has their functions. The meniscus, for example, are semilunar fibrocartilages that are found on the um, they are found sitting on the superior aspect of the tibial condyles. They are usually C or wedge shaped in shape, and they tend to act for different reasons. They tend to act for different roles. They act as shock absorbers of the knee joint. They help in facilitating combined sliding, rolling, and spinning movements. They assist in lubricating the synovial membrane. They help in deepening the articular surfaces. Just a bit of differences between them. The lateral meniscus tend to cover a larger area compared to the medial meniscus, and it tends to form extensions. The extensions of the lateral meniscus are usually known as Humphrey and Risberg ligaments. Just a side note for you to remember. For the anterior cruciate ligament, which is the ligament in blue, it's compared to the posterior cruciate ligament, it's a weak ligament that runs from the femur to the tibia. It's a weak ligament that tends to slack when the knee is flexed and tends to be stronger when the knee is extended. That's important to note. So anterior cruciate ligament is slack at the flexed knee and taut or strong at an extended knee. One important thing to note about the anterior cruciate ligament is that it prevents posterior displacement of the femur on the tibia. So let me draw what I mean. So if this is the femur and this is the tibia, the anterior cruciate ligament, which is running like this, will prevent posterior displacement of the femur. So it prevents posterior displacement of the femur on the tibia. Or we say that it prevents hyperextension of the knee. That's a better way to put it. The posterior cruciate ligament is stronger compared to the anterior cruciate ligament. It's the ligament in yellow. It also runs from the femur to the tibia. It tends to be tighter or stronger when the knee is flexed. It tends to be lax when the knee is extended. And in terms of its function, now this is usually in contrast to what we see for the anterior cruciate. The posterior cruciate tends to prevent displacement of the femur on the tibia, anterior displacement. So it prevents anterior displacement of the femur on the tibia, or we can say it tends to prevent hyperflexion of the knee. So it prevents hyperflexion of the knee or anterior displacement of the femur on the tibia. And that's what we need to remember about the posterior cruciate ligament. The transverse ligament is really not spoken about so much, so we'll just remain silent on that. Let's talk about the other component of the knee joints. This will include the popliteus tendon. I mentioned this when talking about the difference between the lateral and medial collateral ligament. Remember that the popliteus tendon tend to separate the lateral collateral ligament from the fibrous capsule and the lateral meniscus. Then we have some bossas found within the knee joints. We have majorly four bossas of the knee. We have the suprapatellar bossa in blue. It's a bossa that tends to separate the the tendon of the quadriceps femoris from the femur. Then we have the prepatellar bossa. Prepatellar bossa is a bossa found just in front of the patella. It separates the patella from the skin overlying it. We have the infrapatellar bossa. The infrapatellar bossa is bossa in yellow. This is a bossa that tends to separate the skin from the patellar tendon and also separates the patellar tendon from the tibia. And then we have the anserins bossa. Anserins bossa is a bossa found posteriorly. It's also called semimembranosus bossa. It tends to separate the tendons of the semimembranosus muscle from the underlying bone. Bossas are simply extensions of synovial membrane, and they help in cushioning the frictional effect of tendons, bone, skin on one another. What's the blood supply to the knee joint? Knee joint is supplied by a number of different vessels. This includes what we call genicular branches coming from the popliteal artery. We also have descending branches coming from the lateral femoral circumflex artery, and then we have the anterior tibial recurrent artery giving off branches supplied in knee joint. And you can see a picture of each of these anastomosis together to give a rich supply of blood to the knee. The nerve supply to the knee joint follows the Hilton's law. Hilton's law states that the nerve supply to muscles around or acting on a joint would also supply that joint. So we have the femoral nerve, the obturator nerve, sciatic nerve, and the branches of the sciatic nerve, the common peroneal and the tibial nerve being nerve supplies to the knee joint. What are the muscles and movements involved in the knee joint? For the movements, remember the knee joint is a hinge joint, and it is involved in doing a uniaxial movement of flexion and extension. But remember, I also mentioned the fact that it's a modified hinge joint. The reason why it's modified is because it has some form of rotatory movement, and this rotatory movement includes slight internal rotation and external rotation. In terms of flexion and extension, the muscles involved flexion would be the hamstring muscles, which are combinations of three muscles of the posterior part of the thigh: the gracilis muscle, the gastrocnemius muscle, the plantaris muscle, and the popliteus muscle. For extension, we have the quadriceps femoris muscle, which is extended from the patellar tendon. And then the um, internal and external rotation are done by, for internal rotation, we have the sartorius muscle, gracilis muscle, and semitendinosus. And for external rotation, we have the biceps femoris and popliteus muscle. In terms of the movement, flexion and extension of the knee joints involves the movement of flexion. It involves the movement of the leg posteriorly, as away from the trunk, and then for extension, it involves the movement of the leg anteriorly towards the trunk. This is in contrast to what we see when talking about the hip joint. Hip joint flexion is movement towards the trunk. That's movement of the thigh towards the trunk. Extension is movement of the thigh away from the trunk. So please take note of that difference when talking about flexion and extension of the knee joint. The rotatory movement of the knee joint brings us into the concept of locking and unlocking of the knee. So locking and unlocking of the knees would occurs whenever we have the knee being flexed or extended, and this is to ensure stability and mobility of the knee at different particular positions. So when we say the knee is being locked, what that means is that we go from a flex to an extended position. And for us to go from flexion to extension, we have some form of rotation occurring in between. And that rotation is what we call a medial rotation. So medial rotation is what helps in locking the knee. Then when we want to go from an extended to a flex position, we say the knee is being unlocked. So the unlocking of the knee from extension back to flexion usually requires a form of rotation, and that rotation is the lateral or external rotation. So please note, for us to lock the knee, we go from flexion to medial rotation to extension. Then we say the knee is locked. For us to unlock the knee, we go from extension to lateral rotation to flexion. We say the knee is unlocked. One important thing to note is that the muscle for undergoing lateral rotation is the muscle that is involved in unlocking, and that muscle is the popliteus muscle. The popliteus muscle is the major muscle for unlocking of the knee because it's a major muscle for lateral rotation. The last important joint of the knee is the ankle joint. The ankle joint is also called the talocrural joint because of the various bones involved in forming the joint. So to form the ankle joint, we require the tibial bone, the fibular bone, and the talus. The ankle joint is a type of joint regarded as a hinge joint. It's uniaxial, so it's involved in movement at one plane, and it's synovial in form. And we'll talk about the different components of the ankle joint in terms of its synovial complex. The articular surfaces of the ankle joints includes the medial and lateral malleolus of the tibia and fibula respectively, and then the superiormost part of the talus. In terms of its components, remember the ankle joint is a synovial joint, so it is made up of synovial complex. This involves the joint capsule alongside tendons and bursa. The joint capsule would have fibrous capsules on the outer part and synovial membrane on the inner part that will line a synovial cavity. The important tendon of the ankle joint is called the Achilles tendon. It's the tendon of the gastrocnemius and soleus muscle that combines together to attach at the calcaneus. You can see the tendon, very large tendon attaching at the calcaneus of the feet. And then we have some bursas found in the ankle joints. The bursa in particular is the bursa found around the Achilles tendon. What are the ligaments of the ankle joints? We have a number of ligaments that tend to stabilize the ankle joints. This ligament includes the medial collateral ligament, also called deltoid ligament, and the lateral collateral ligament. We'll talk about that in the next slide. The medial collateral ligament is actually a combination of four subparts or four subligaments. This includes the tibio-navicular ligament, the ligament between the tibia and the navicular bone, the tibio-calcaneal ligament, the ligament between the tibia and the calcaneus, the posterior tibio-talar ligament, which is the ligament between the tibia and the talus and posteriorly, and the anterior tibio-talar ligament between the tibia bone and the talus anteriorly. You can see each of these ligaments here labeled in the image here. You can see the tibio-calcaneal ligament, tibio-navicular ligament, anterior tibio-talar ligament, and posterior tibio-talar ligament, all giving rise to the deltoid ligament. For the lateral collateral ligament, we have three major ligaments giving rise to this ligament, which includes the anterior talofibular ligament, the posterior talofibular ligament, and the calcaneofibular ligament. Each of these ligaments are shown. You can see the anterior tibiotalar in the image here. You can see the calcaneofibular ligament, and then we could also see the posterior tibiotalar ligament. The blood supply to the ankle joint is from a number of different vessels. This includes the malleolar branch of the fibular artery, the malleolar branch of the anterior tibial artery, and the malleolar branch of the posterior tibial artery. The nerve supply to the ankle joint follows the Hilton's law, and this states that the nerve supply to muscles acting on a particular joint will also supply to joints. So the tibial nerve and the deep fibular nerve are nerve supplying muscles around the ankle joint, and they are nerves that will supply the ankle joint itself. What are the movements at the ankle joint? We have the movement of dorsiflexion and plantar flexion. The muscles involved in each of the movements would include, for dorsiflexion, tibialis anterior muscle, the extensor hallucis, and the extensor digitorum longus muscles. For plantar flexion, we have the gastrocnemius, the soleus, plantaris, and the posterior tibialis muscle. Each of these muscles we'll talk about when we get to the module of muscles of the lower limb. And these are the movements occurring at the ankle joint. We have the dorsiflexion of the feet, which is movement of the foot towards the leg, and then plantar flexion is movement away from the leg. Really remember dorsiflexion as standing on your heel, and plantar flexion as standing on your toes. There are some other movements shown above. These are the movement of inversion and eversion. But what you need to note is that these movements are not done at the ankle joint, but they're done at the separate joints of the feet called the subtalar joint. Let's end with clinical significance to the joints of the lower limb. This includes the Trendelenburg gait sign. I'll show you pictures of this. Waddling gaits, which is usually a problem with pelvic fractures. Fracture of the femoral neck. We talked about this when talking about the bones of the femur. Dislocation of the hip joints, coxa vara and valga. I'll show you pictures of this. We have what we call the unhappy triad of the knee, which is a problem when there's a trauma to the knee joint and there's a damage to various intra and extracapsular ligaments of the knee joints. Knock knee and bow leg, which is what we call genovarogum genovarum. I'll show you pictures of that very soon. Patellar tendon reflex. This is very important when doing a musculoskeletal examination in clinical school. You learn about this with use of a patellar hammer. The prepatellar bursitis, what we call housemaid's knee, and infrapatellar bursitis, what we call clergyman's knee. This is inflammation of bursas, as mentioned. I'll show you pictures of this. Then ankle sprain and port fracture. Port fracture is usually fracture around the ankle joints. The fracture including damage or breakage of the medial lateral malleolus alongside dislocation of the ankle joint, and that's what we call a port fracture. I'll show you pictures of a few of this in the next slide, and I'll talk about each of them one by one. This is a man with a Trendelenburg gait. Trendelenburg gait is when there is an instability of the pelvis due to laxity or paralysis of the gluteus medius and minimus muscle. I'll show you a picture of how we can assess for Trendelenburg sign or Trendelenburg gait. But what you need to note is that a patient with Trendelenburg gait would have their pelvic region not being aligned. As you can see in the first image, you can see that the pelvic region on the right and the left side are thoroughly aligned. On the left side, you can see that the pelvic region on the right and left side is slightly tilted towards a particular direction. And that's what we call the Trendelenburg gait. Like I said, it's due to problems with the gluteus medius and minimus muscle. Gluteus medius and minimus muscle are supplied by the superior gluteal nerve. So if there's a problem with the superior gluteal nerve, this affects the gluteus medius and minimus muscle, and this will lead to what we call the Trendelenburg gait. So we assess for the Trendelenburg gait by what we call the Trendelenburg test. And what we ask the person to do is that we ask the person to stand on one knee, on one leg rather. And once the person is standing on one limb, if the pelvis is aligned on both sides, right and left side is balanced, that's a normal Trendelenburg test. Whereas if we have the pelvis slanting to one side, so in this image, this is the left side, this is the right side. The pelvis in this image is slanting to the left side. Whatever side that pelvis is slanting towards will show where there's a weakness. So will show where there's a weakness to. So what this means is that wherever side the pelvis, if the pelvis is slanting to the left side, then it means the opposite side is where the problem is. So the slanting is on the left side, the symptoms on the left side, but the problem is on the right side. The reason is because the muscles on the right side are weak. So we have weak gluteus medius and minimus muscle, whereas the muscles on the left side are normal. So because the muscles on the left side are normal, they will be pulling the entire pelvis towards the side. So we have the pulling of the pelvis on that left side due to the fact that the muscles on the left side are contracting well. If the muscles on the right side were normal, there will be equal pulling on both sides, and that will lead to a normal aligned pelvis. But in the case of the picture on the other side, you notice that the weakness is on the right side, hence the muscle on the left side is pulling the pelvis and slanting it towards the left, and that's what we call a positive Trendelenburg sign. And like I said, it's due to weakness of the gluteus medius and minimus. What you need to remember is the nerve supply. The nerve supply to the gluteus medius and minimus is the superior gluteal nerve, and that's what is affected. So this is an image showing us the deformities that could occur at the femoral neck and at the knee joint. So at the femoral neck, we have what we call the coxa varum or coxa valga deformities. This usually tends to stem from deformities of along the axis or angle between the femoral neck and the femoral shaft. So normally the angle between the femoral neck and femoral shaft should be between 120 degrees to about 140 degrees. Whenever there's excessiveness or a reduction in this particular angle, then we could have the valgar or varum deformity at the femoral neck. If it's a valgar, we have an excess of the angle. So we have the angle being more than 140 degrees. If it's a varum, the angle is less than 120 degrees, and that's what we tend to see. For the deformity of the knee joint, which is the genome valgum or varum, there's usually an excessive displacement of the knee joint. So in the varum, there's an excessive displacement of the knee joint that will lead to what we call a bowing deformity, or what we call bow leg deformity. The knee joint is displaced laterally, and that will lead to a bow-like deformity. For genome valgum, we have a medial displacement of the knee joint. So the knee joint is displaced medially, and as a result, it gives rise to the deformity we call a knock knee or key leg. So here's picture showing us the different deformities as described before: coxa valgum and varum, and then the normal coxae. Coxa valga, like I said, is a deformity whereby we have excess in the angle between the femoral shaft and femoral neck. Usually the angle is really more than 140 degrees. Then coxa vara is when we have deformity whereby the angle between the femoral shaft and femoral neck is less than 120 degrees. This is a live image of a patient with a genovalgum varum. This one is particularly showing genovalgum. This is what we call a knocked knee. You can see that the knee is displaced medially to give rise to that key leg appearance, or what we call a knocked knee. For the bow leg and knock knee, that's the genovalgum valgum, as I said. Usually the problem is usually um, in the axis from the head of femur down to the knee joint. So the axis is meant to be a straight path, but whenever there's a alignment between the head of femur and the um, the knee joint, then we could have genovalgum or varum being occurring. In the case of genovalgum, we have that line, that particular axis being medial to the knee joint. In valgum, we have it being lateral to the knee joint, and that's how we tend to arrive at that displacement mentioned. This is an image of what we call the unhappy triad of the knee. This occurs when there's a lateral force being applied to the knee joint. So the force will come out laterally, hits the lateral part of the knee joint, and what it results in is it damages to different ligaments of the knee. So what we tend to see is that there's a damage to the anterior cruciate ligament. There's also a damage to the medial meniscus, and because the medial meniscus is attached to the tibial collateral ligament, there's also a rupture of the tibial collateral ligament. So there's a damage of three major structures of the knee joint. Hence the reason why we call it unhappy triad of the knee. This was one condition that happened to a popular striker in Liverpool. That's Virgil van Dijk. I think it was his first season or second season in Liverpool, and he had this terrible injury to the knee, which resulted in the tear of his cruciate ligament alongside the others, and he had to be out of football for about, I think, about 9 months. I think it happened around November. He came back probably later on towards the end of the season. Finally, we have the two forms of bursitis that we see in the knee joints. We have the prepatellar bursa and prepatellar bursitis and infrapatellar bursitis. Prepatellar bursitis tend to occur in housemates. We usually call it housemate's knee because of their constant use of the knee when cleaning surfaces, maybe floor or surfaces around. So they constantly strain the prepatellar bursa, and as a result, that will lead to bursitis. In the case of a clergyman's knee is usually due to problems with the infrapatellar bursa. So as you can see, this is a clergyman. The way in which he kneels down is different from the way in which an housemaid will kneel down. And as a result, what tends to be affected is the infrapatellar bursa, not the prepatellar bursa. That concludes our module on the joints of the lower limb.